Good afternoon, everybody. It's a pleasure to meet you, even if it's through a webinar. My name is Carolyn Carville, and I've been given the privilege today to talk to you about heel pressure injuries, combating Achilles' legacy. And the reason that we are here is because we're here today to acknowledge a really important day in the year, and that is Stop Pressure Injury Day. It's been celebrated around the world in different ways, and our webinar today is to not only remind us that there is much we can do to prevent pressure injuries, but in particular to prevent heel pressure injuries. Our aims and objectives are as outlined here. Our overriding aim, rather, is to review the lessons from the past in light of current evidence for heel pressure injury prevalence, rather prevention and management. And this information and the evidence we're going to pull from the International Guidelines as we go through the presentation. At the end of this presentation, I'm hoping that we will all be better informed to identify patients at risk of developing a heel pressure injury, to describe stages of pressure injury, to explain the influence of microclimate on pressure injuries, to list strategies that can prevent the development of heel pressure injuries, and to discuss treatment options, again, for heel pressure injuries. But the question to begin with is why? Why in 2016 we still have pressure injuries? In light of the fact that 10 years ago we had a 960% increase in publications which focused on pressure injuries. In light of the fact that we have huge advances in support surfaces and devices for offloading pressure. In light of the fact that we have an enormous resourcing of education, not only to health professionals and carers, but to consumers of health at the same time. In light of the fact that we have increased patient expectations, and most importantly, we have accreditation demands to reduce pressure injuries. So heel pressure injuries, like all pressure injuries, I believe are preventable. They are extremely costly to manage. They are a huge impact on those that not only have the infliction, but those that care for them. And of course, as we know, with heel pressure injuries, they can lead to amputation and subsequent detriments to mortality. Back in 2012, the Australian Wound Management Association, which is now Wounds Australia, the New Zealand Wound Care Society, the Hong Kong ET Nurses Group, and the Singapore Wound Healing Society came together and formatted the Pan-Pacific Pressure Injury Alliance. And as a result of that, we published the guideline in 2012. The day we actually published or released the guideline in Canberra for draft comment, we were invited by the NPUAP and EPUAP to come together for the development of their guideline, which was to be published in 2014. This opportunity we took up with great enthusiasm because we could see that it was one step closer to expanding an international consensus. And the document that resulted from that is known as the International Guideline, but it's the Prevention and Treatment of Pressure Ulcers, a Clinical Practice Guideline. The strength of evidence in this document, which throughout this presentation I will abbreviate strength of evidence to SLE on the slides, was drawn from direct evidence from over 350 clinical trials, as well as additional indirect evidence. There were individual studies were assigned a level of evidence based on the study design and quality, and the body of evidence supporting each recommendation was given a strength of evidence. The allocation of evidence was A to C. A was a recommendation supported by direct scientific evidence from properly controlled or designed and implemented controlled trials on pressure ulcers in humans. That is a level 1 study, and there were 6 of those. A B strength of evidence was that there was a recommendation supported by direct scientific evidence from properly designed and implemented clinical trials on pressure ulcers in humans, were the level 2, 3, 4, and 5 studies, and there were 71 of those. And when there was insufficient evidence, we gave it a C ranking, which demonstrated a recommendation supported by indirect evidence and or expert opinion. And as you can see, there were many of those. The strength of recommendation or grade was a new innovation in the development of this guideline, A recommendation is the extent to which one can be confident that adherence to a recommendation will do more harm than good. So our consensus-based recommendations were dependent upon all of the guideline development members who were invited to participate in the grading process. And the grading process was based on the strength of internal and external evidence, the clinical importance of the work, the potential to improve patient outcomes, their feasibility, and the cost-effectiveness of the recommendation. So in the International Guideline, there were 575 recommendations. And as you will see on this slide, 2 thumbs up indicated that it was a strong positive recommendation, or if you like, we should definitely do it. 1 thumbs up indicated a weak positive recommendation, and we should probably do it. If the hand was parallel, there was no specific recommendation, and I'm pleased to say that there were no weak negative recommendations or strong negative recommendations made in the guideline. So let us begin by considering the heel. And it was Michelangelo in the 1500s that said, what spirit is so empty or blind that it can't recognize the fact that the foot is more noble than the shoe, and the skin is more beautiful than the garment in which it is clothed. And I think Michelangelo's statement, for me personally, identifies the fact that the foot is a rather extraordinary structure in the human body, and it is extremely vulnerable. Its vulnerability, I think, was very much emphasized by the Legend of Achilles, which is why I chose this title of this presentation. Thetis is the mother of Achilles, and she was a mythical goddess. And she endeavored to immortalize her son Achilles by several ways. Firstly, burning him over a fire every night, and then she dressed his wounds with an ambrosial ointment. But finally, she dipped him into the river Styx because the waters were considered to confirm invulnerability of the gods. But as you can see in this painting by Rubens, when she gripped his heel to dip him into the river, the water from the river didn't actually contact his heel. So that remained his vulnerable site, and where he was, if you like, his only mortal site in his body. When we look at the mythical adventures of Achilles, he was considered a great warrior in the Trojan Wars and before and beyond. And it was such that he was quite feared by all of those around him. And it was really an act of revengeance, or vengeance, if you like, by... Oh, we're having another problem again. Oops, go back one. By Achilles was ambushed on his return to Troy by Paris, and Apollo, who was the mythical god, was particularly angry with Achilles, and he guided Paris's arrow to hit the vulnerable part of his body, which of course was his heel. So that's the reason he died. So if we actually look at the foot, it contains 26 bones. They are exquisitely put together to form an amazing structure that is going to support the weight of the body. And if you think of how we apply pressure to the foot as we walk, as we jump, as we move, the activities that we do to jam them in are often into quite close-fitting shoes, particularly high heels. There is a lot of pressure applied to the largest bone on the body, which is the calcaneus. And if we look at the soft tissues in the body, the posterior tibial and peroneal arteries supply the heel. The number of heel capillaries and the density of fat over the calcaneus decreases with aging, which is why our elderly patients are more vulnerable to heel ulcers. The perforating branches of the peroneal arteries supply the lateral aspect of the skin and the heel, and the medial calcaneal branch of the posterior tibial artery supplies the heel pad. But the thin skin at the back of the heel and the lack of muscle and fat posterior make the posterior position of the heel particularly vulnerable to a sustained pressure and shear and friction. So we know from those prevalence and incidence studies that are available that the heel is the second most common site for a pressure injury. What I'm sharing with you now is some data from the organisation in which I work in Western Australia. And Silverchain is the community nursing not-for-profit organisation. And this is the data from October last month. And of the 6,271 wounds that we cared for last month that were either referred to us or were internal care needs, we had 490 pressure injuries. And if you look at those pressure injuries, particularly on the posterior surface of the digiman presented here on the right, you can see that heel ulcers constitute a significant number, and in particular, they would be described as the second largest group of pressure injuries. Aligned with that, we had 821 foot ulcers. And as we know, quite often foot ulcers are aligned to arterial disease or, if you like, the diabetic foot injuries. And many would suggest that a diabetic foot injury, particularly on the plantar surface, occurs as a result of pressure or some sort of localized trauma. And many of these, of course, are often confused with pressure injuries, or if you like, pressure was the leading cause of that injury. So it is critically important with any foot wound that we identify the lower leg vascular status and that we undertake a comprehensive assessment not only of the blood flow to the limb, but certainly its neuropathic status as well, to identify whether or not we have a pure arterial problem or whether we have a pressure associated with an arterial problem or a neuropathic problem. So what I want to show from you here is that it is a significant injury. If you look at the way or think of the way you lay in bed at night, most people will lay in bed with their feet in many different positions. And the important thing here is that pressure on the fat pad of the heel, when it's positioned at a 90 degrees to the leg at a bed rest, is higher than the foot when it is in a lateral position. And if the foot is positioned over a tight bed cover, then there will be even a higher pressure still. So when you're in bed tonight, think about the way you're positioning your feet, because it doesn't take very long before you automatically seek a more comfortable position, and you tend to turn your feet to a lateral position, as is demonstrated in the lower picture. And with that positioning, there may be an element of comfort, but this also explains why most heel pressure injuries are not directly over the tip of the calcaneus, but slightly lateral to it. So some facts about the heel that we know. We know that there was a study conducted in the United States that found that 18.2 to nearly 29% of pressure injuries, there was a prevalence of up to 29% of pressure injuries and an incidence of 23.6 to 26%. Within that study, they found that healing times could take over 1 year to heal a pressure injury due to usually the comorbidities of the individuals. In a study of 450,000 patients, heel ulcers accounted for 41% of the suspected deep tissue injuries that were found. And in one Australian study, we found hospital-acquired pressure injuries in that 2002-2003 cohort, again, constituted the second largest number of hospital-acquired wounds that were on the heel. And 11% of patients with advanced ischemic heel pressure injuries required amputation, and compared with a group of patients with pressure injuries on other sites of the foot. So again, this provides evidence that we need to conduct a very comprehensive lower leg assessment. One of the impacts on the tissue is tissue distortion. So pressure is perpendicular force. But what occurs when we apply localized pressure, it contributes to pressure injuries by deforming the skin and the soft tissues, and particularly over a bony structure. And it's such as the bed. And what happens is that there's distortion of the cells, which causes reduction of blood flow and ongoing ischemia, which further compromises perfusion to the skin. So our International Guideline tells us that it's most important that we determine the reposition frequency, and in considering that, we need to consider the person's tissue tolerance, the level of activity and mobility, their general medical condition, overall treatment objectives, and the skin condition, and of course the comfort of the patient. So that was a C recommendation, level of evidence, and a 2 thumbs up recommendation. Also, the guideline stipulates that it's important that we reposition in such a way that pressure is relieved by redistribution. And again, that has a 2 thumbs up recommendation we should do. Thank you. Shear stress is another factor, and shear results from tangential, or if you like, parallel force applied to the skin. Whilst the deeper tissues remain stationary, the tissues become deformed. And that, of course, occurs more, becomes more problematic when skin coefficient of friction is affected. That is, if you like, the skin's resistant to friction. And that occurs certainly in the presence of moisture. So our guideline tells us that we should consider using silk-like fabrics rather than cotton or cotton blend fabrics to reduce shear and friction. And we need to use manual handling aids to reduce friction and shear when repositioning the individual. So I'm now going to open to questions that I've listed here for you just to reflect upon the content so far. At the end of this presentation, we'll have open questions, and we invite you to submit online through your portal questions at any time, and we will address those at the end. So question 1 is now open. Okay, our response was question 1 was 82%. That is, the heel is positioned at 90 degrees to the leg during bed rest, and of course that was correct. We had 5% to question 2, 7% to question 3, and 5% to question 4. Thank you. We'll move on. Again, let us return to the past to look at some of the lessons that we've learnt and to identify whether or not the evidence today reflects the lessons of the past. It was the ancient Egyptians around 5,000 years BC that reported, well, not so much they reported, but in the mummies that have been discovered, the pressure injuries were found to be evident within this population. Importantly for us, of course, we can't wait 5,000 years to get an answer about the risk to an individual. And what it's important is it's been identified in the guideline that we need to ensure a complete assessment is part.
Sorry, you need to webcam. Keep talking.
We need to ensure a complete skin assessment is part of the risk assessment screening policy in all healthcare centres. That's a must, as you can see. And we need to educate health professionals on how to undertake a comprehensive skin assessment that includes techniques for identifying blanching response, localised heat and edema and induration. And that's a B level of evidence and a definitely must do. And as we know, the Australian Commission for Safety and Quality in Healthcare and Standard 8 also dictate under 8.2 the need to use a risk assessment framework and reporting system to identify, investigate and take action to reduce the frequency and severity of pressure injuries. And that information from the routine identification and review will identify risks that can be used to focus improvement activities. And of course, reporting and feedback systems to executive and clinical staff to investigate and improve strategies are most important for preventing pressure injuries. So back to ancient times. It was Hippocrates, who lived 460 to 379 BC, who described a pressure injury in association with paraplegia, with bladder and bowel dysfunction. And of course, we know today that can be a major issue. In the International Guideline, there's a complete section that is dedicated to prevention and management of pressure injuries in individuals with spinal cord injury. And we know that we provide adequate seat tilt to prevent sliding forward. We need to adjust our footrests and armrests. We need to employ variable positioning for seating, to weigh the risks and benefits of supporting an individual in bed versus seating. And there's some evidence about continued or consider the use of electrical stimulation for the treatment of paraplegics with spinal cord injury. Ambrose Paré in 1542, wrote in his autobiography about a French aristocrat who developed a pressure injury. Paré's advice to the care and management of that individual was to advise or to offer good nutrition, good pain relief, and to undertake debridement of the pressure injury. In the International Guideline, there are 29 recommendations that focus particularly on nutrition. And the 4 that I have chosen here today is that there's a need to assess the adequacy of nutritional intake, the evidence is C, to provide individualised energy intake and supplement as required, to provide 30 to 35 calories per kilo body weight for adults at risk, and to provide 30 to 35 calories per kilo body weight for adults with a pressure injury and malnutrition, and of course similar undertakings for infants. For pain management, as advised by Pereire, in the International Guideline there are 22 recommendations, and they outline the need to assess for pressure injury pain, to prevent pressure injury pain, to manage pressure injury pain, to reduce procedural pressure injury pain, to manage chronic pain, and to educate individuals, families and healthcare providers about pressure injury pain causes, assessment and the need for management. According to Pereire, there was a need to debride, and in modern times that's still seen as an important thing, particularly in the presence, of course, of necrotic tissue or suspected biofilm or infection. And in the guideline there are 13 recommendations we might like to review in regard to debridement. But it was Florence Nightingale in about 1881 rather, who wrote in her diary on reading the nurse probationers' records of how they were managing their patients. She wrote, "There's an immense amount of zinc rubbing, but I haven't met with a single observation as to whether there is a danger of bedsore." Bedsore was the term they used in those days because the bed was seen to be the problem. But I think Miss Nightingale was 100 years ahead of her time, because it was to be about 100 years before we started to use risk assessment tools to help us identify those at risk. And of course, Standard 8 again identifies the need for a risk assessment, and that it's performed using a scale or a score that identifies those risk factors, and that we conduct that risk assessment on admission or as close as possible, and certainly within 8 hours. And that our assessment tools, whether we use the Braden scale, the Waterloo score, the Norton scale, but those scores need to identify those parameters listed here, such as clinical history, mobility and activity, intrinsic factors, the extrinsic factors, the nutritional screening, continence, cognition and sensation. So, as outlined in the guideline, there is a need to assess the heel specifically, and we need to inspect the heels regularly, and we need to remove heel devices periodically, and certainly on each time we inspect, to actually determine the condition of the heel skin. The assessment frequency should be, as outlined by our Australian Commission for Safety and Quality, within 8 hours of admission, hopefully much sooner than that. And we need to repeat the assessment as often as required by the individual's acuity. We need to undertake an assessment if there is a significant change. And it's also important, particularly in regard to medical devices, and as we can appreciate, quite often they're associated with heel suspension devices, to assess the skin under and around those medical devices at least twice a day. So back to historical times. It was actually Charles Edouard Brown Seguard, who was a French physician, who back in the late 1980s did some experiments on guinea pigs. And what he wrote was that he found no ulceration appeared when he took care to prevent a continued state of compression, and then he washed them to remove the urine and the feces from their skin. So what do we learn from him, and what do we learn from the guidelines? Well, we have a great need for good skin care. And the main principal points are that we need to keep the skin clean and dry. We need to use a pH balance cleanser. We need to protect the skin from exposure to excessive moisture. And we need to consider using a moisturiser to provide external topical hydration. So we now come to question 2, and the questions that will show up on your screen. We will open the poll. Okay, we'll close the poll now. And we'll look for our responses. So in response to the question, when should a risk assessment be undertaken? The answers were, only if the patient is mobile, no. And question 2, daily, had an 8.6%. The answer's not ideal. C, ASAP on admission, subject to acuity and change of condition, and 88% of people saw that as correct. And 6% saw that ASAP on admission, subject to acuity. So ideally, we will conduct a skin assessment as soon as possible on admission, subject to acuity and changes of condition in the individuals. So let us return to the presentation. Another lesson we learned from history came from Jean-Martin Charcot, who again in the early 1800s stated that we now have the prime cause under which a bed sore is produced. And according to Charcot, he considered that it was a spinal lesion that was the cause of the problem, and he referred to pressure injuries as neurotrophic ulcers. Throughout history, the term has been given many names, or rather, if you like, the condition has been given many names. Bed sores was the favoured term in the 1800s because, as I said, the bed was seen to be the problem. Pressure ulcers, decubitus ulcers, and pressure areas is a term that's commonly used. But the term pressure injury became much more relevant and certainly more commonly used across our Pan-Pacific region with the launch of the new Pan-Pacific Guideline in 2012. And prior to that, the Australian Standard 8 that was launched. In the development of the International Guideline, there was great debate between our partners, the EPUAP and the National Pressure Ulcer Advisory Panel, and they felt at the time that pressure ulcer was such an entrenched term within their regions that it was just a bit premature to change to pressure injury. So the term pressure ulcer was maintained in the guideline, but of course with permission for the Pan-Pacific region that they would use the term pressure injury. The definition for pressure injury stayed the same in the guideline as was previously published in the 2009 International Guideline between NPUAP and EPUAP, and as was the staging system. So as it stands at the moment, the staging system as outlined in the International Guideline, which is a stage 1 where you have non-broken erythematous skin that doesn't blanch, stage 2 where you have a superficial pressure injury that exposes the dermis, stage 3 down into subcuticular tissue, stage 4 down through muscle, bone or tendon, unstageable where the wound is covered with eschar or slough and prevents us determining the depth of the injury, or the suspected deep tissue injury where we have intact maroon, blue, black, brown staining of the skin or hematoma under the skin. As it stands at the moment, even though NPUAP have suggested new staging definitions, Wounds Australia and the Guideline Development Group, which does include NPUAP, EPUAP, propose that we maintain these definitions until we have developed a wider consensus, which hopefully would involve the World Health Organization in the development of the 2019 guideline, and the work for that will commence next year. And what's particularly important from an Australian perspective is that our ICD coders lobbied the World Health Organization, and on 1st of July last year, we introduced in Australia an ICD-10 Australian Modified 9th edition, and that allows our coders to code according to the pressure injury definition and staging definitions that are currently in the 2014 International Guideline. And we hope that in the next edition, and we're sure that the term pressure injury will be more universal across other parts of the world, and again, that we have a broader consensus for staging definitions. So risk factors for heel ulcers can be either vascular, neuropathic, or physical. Those that are vascular involve peripheral arterial disease, stroke, vasopressive medications, the presence of compression garments that are poorly fitting, and smoking. Those that comprise neuropathic conditions would be peripheral neuropathy, usually secondary to diabetes, autonomic neuropathy for similar reasons, spinal cord injury, impaired cognition or spasticity. Physical risk factors would include malnutrition, particularly low albumin, limb weakness due to fractures or knee or hip replacement, extended bed rest periods, and anything that impacts on the skin coefficient of friction, and the common impact there would be moisture, and alteration in microclimate, which again has moisture as one of its contributing issues. In the guideline, you'll find that all support surfaces are now grouped under 2 headings: reactive or constant low pressure, and active, which is alternating pressure. When selecting the correct support surface for heels, like we would for pressure injuries on other anatomical positions, we need to consider many things, particularly the risk factors as outlined, and certainly the mobility and activity of the individual. So we would conduct our risk assessment using a validated scale, and according to our score, we would allocate risk. And many of you will have parameters in place in your facilities where risk is accorded a certain level of pressure support offloading. So the non-powered reactive devices include those media such as foam, gel, air or combination, powered, usually low air loss or other powered reactive devices that involve the patient immersing into the device rather than being alternated, as would occur on an alternating or active pressure offloading device. The important thing with support surfaces, according to the information in the guidelines, is that we need to use an appropriate support surface for all at-risk patients. We need to select the support surface that provides enhanced pressure redistribution, shear reduction and microclimate control for individuals with stage 3, 4 or unstageable ulcers. And we need to have guidance on product selection and use is covered very well within the guideline. When it comes to heels, we need to ensure that the heels are offloaded, and quite often people will select a support surface such as a mattress, thinking that they're getting adequate support under the heel, which of course is a smaller diameter as compared to a larger torso. And so we need to remember that heels are only offloaded, or rather the pressure is only reduced when the heel is completely offloaded. And so we need to select a pressure offloading device that does that really well. What you can see in the graph here is an example of a patient that has been laying on a Nimbus 4, and this has special ability under the heel for the cells to drop significantly. So we can see here that the patient's major pressure points are all within an acceptable standard, and that's how it should be with all people. Bedclothes, of course, shouldn't be tucked in tightly. We need to encourage people to move their feet, but of course, if you have a tightly tucked in bed clothing, you're going to end up with more pressure applied. And anything left at the end of the bed, such as folded blankets or other objects, again, will increase the pressure to the heel. When it comes to microclimate, that's the temperature and humidity of the interface between the support surface and the individual's skin. We need to be mindful of the causes and effects. We know that in regard to pressure injuries, the mechanical conditions, such as the magnitude of the pressure, the time or duration of the pressure, and the type of loading in the form of shear, pressure, and friction impact on internal strains and stresses to tissue. And the individual susceptibility to that pressure is very much determined by the mechanical properties of the tissue, the individual geometry of the tissue and the bones. And again, I just highlight the fact that the calcaneus is a very finely pointed bone at the end, and the tissue skin over that, such as the fat and the skin, are rather thin. And the individual physiology and repair process, and the individual transport and thermal properties of the person's skin. And of course, these are compromised again in the presence of moisture, and increased temperature also will impair the response to pressure, shear, and friction. Additional microclimate management strategies we need to consider, as outlined in the guidelines, is the need to avoid all heating devices, the need to keep the skin clean and dry, and the need for continence management strategies. When it comes specifically to heel devices, we need to ensure the heels are free of the surface of the bed or whatever their contact surface might be, and that ranks a level of evidence as a C. We need to use heel suspension devices that elevate and offload the heel completely without placing pressure on the Achilles tendon and subsequent problems that would create. The knee should be kept at a slight flexion, usually between about 5 to 10 degrees. We need to avoid areas of high pressure under the Achilles, and in particular, some of the support surfaces, such as the one down in the left-hand corner, can cause a problem, particularly over the lower calf. And we need to apply heel devices according to manufacturer's instructions. So there are many such devices on the market, but personally I think we still have a long way to go before we come up with the ideal heel support surface. Many of them are made with fabrics that trap the heat, such as vinyl or plastic. To overcome that, some manufacturers have cut holes in them, and quite often I find that the heel or the malleolus falls out of them and has direct contact with the support of the bed. We often find that those that have an elevator in them do well to keep the heel off, but they limit the mobility of the rest of the body. So often I find that pressure injury risk in other parts, such as the sacrum, are increased. So again, we need to look at the whole person in relation to what we are doing to offload heel pressure, or rather heel pressure? Does it also impact on increasing pressure on other parts because of immobility? So again, I send out a challenge to all manufacturers to continually to work to find a support surface for heels specifically. Quite often people come up with what they think are innovative devices, and we need to look at the evidence for them. And the use of the following devices, such as synthetic sheepskin, cut-out rings or donuts, intravenous fluid bags, water-filled gloves, or urinary bags I've seen filled with water and laid under a heel, or for that matter any other anatomical position to try and offload pressure. The evidence is that this increases the pressure and that we certainly shouldn't be doing this. So we now go to our next set of questions that are open, and we'll open the poll for question 3. And the question at hand is, increased skin microclimate changes are due to what? So the question was, increased skin microclimate changes are due to, the first one was increased skin temperature and 0%. The second was increased skin contact with moisture, and the response was 2%. Third one was increased contact with moisture plus increased skin temperature, and I'm pleased to say there was a 96% response to that, so that was the correct response. Thank you very much, and we'll move forward. Pressure injury management, should a pressure injury occur. Within the guidelines, there are lots of recommendations, and because there's so many, I've listed them under these headings, and I would encourage you to review them should you have a need. But we're instructed the importance to cleanse the ulcer, to remove obviously any debris, necrotic tissue. That might involve debridement, particularly when there's adequate perfusion. So the best practice is usually that if there's insufficient blood supply to support infection control principles, then often best practice is to leave the eschar, providing it's dry, in place. Otherwise, debridement as appropriate by the most competent practitioner. The best dressing options to achieve the goals of care, the need to alleviate and manage pain, the need for regular repositioning continues. The need for support surface selection to offload pressure again under the heels is critical. The need for high protein supplements is outlined, and for a surgical review if the ulcer on the heel is not responding to the topical treatment at hand. Specifically, the guideline outlines that need under pressure injuries of the heel, if they're stage 1 or 2, to relieve the pressure, and you may choose to do that by either floating the heels off on a pillow or using a heel suspension device. And for stage 3 and 4 unstageable pressure injuries, the need to place the leg in a device that elevates the heel and completely offloads the pressure. I'd just like to focus, though, on the picture, particularly on the left-hand side at the bottom of the slide. Someone's endeavoured to elevate the heels here, but two things are wrong in this picture, and I'm hoping that you've identified them as well. One is they've used a plastic-backed bluey, and that's going to increase the the heat to the lower limb. And secondly, the heel is unsupported, and as such it's going to drop onto the bed, and thus it's not going to offload at all, and there's the risk of foot drop. So if all that is available are pillows, then we not only need to elevate the length of the leg, the lower limb, but to put a pillow against the end of the bed to have the leg, or the foot rather, at 90 degrees. And if you do this, you'll find that the heel will float and be offloaded. There's also evidence for the use of prophylactic dressings, and that evidence is presented in the guideline. And the prophylactic dressings, where there is some evidence, are the silicone multi-layered foam dressings, and one brand in particular. And the evidence is that it helps to reduce the shear predominantly, and also one assumes to help manage the microclimate. So in summary, as was the case with Achilles, heels are very vulnerable. And so we need to be mindful of the fact that we need to do everything in our power to elevate the heels, to consider them as a special need in the overall anatomy of the patient that we're trying to care for. We need to reposition frequently. We need to use the best device at hand to offload the pressure, and ideally one that is specifically going to target the thin skin and, if you like, the thin fat pad at the posterior part of the heel. So In bringing this together, I would like to encourage you, if you haven't accessed the guideline, you can download a free quick reference guideline from either the Wounds Australia or the ORMA, which is still under the ORMA site, or the internationalguideline.com. And the good news is that today, being Stop Pressure Injury Day, we have a discount. So where it was $50 previously, it is now $37. But don't forget, if you're going to purchase, you need to click the Pan-Pacific Pressure Injury icon on the form when you go to pay. This will also doesn't include postage. So I'd just like to say to you that the next international guideline will be published in 2019. In 2017, that work begins, and Wounds Australia will send out an expression of interest for those that might be interested in joining that guideline development work. And I would encourage you to consider sending in your application, because we would really like to expand the consensus work and the teams that will be working on the small reference group. So I thank you very much, and I'm now going to open this webinar to questions. And I've at the same time listed some websites here that you may like to take note of for further information. So we are open to questions. And so we'll just wait a few minutes for those to come in. It's like waiting for a pot to boil. Excuse me while I lean over. The first question is, excuse me for leaning, are there any studies on, thank you. Are there any studies on slide sheets to assist in to assist in bed transfers, and if these cause pressure injuries or make them worse? Interestingly enough, within the guideline, the use of slide sheets, as was other devices such as gooseneck elevators, were a consensus-based recommendation. To my knowledge, there have been no specific studies in using slide sheets, but there certainly was a consensus around eliminating shear and friction, and the use of slippery, non-resistant materials to do that, and i.e. slide sheets being one, is probably something that at the moment we consider necessary. But it's a good opportunity. If somebody is interested in doing a study, I would encourage it to do. The second question, in risk assessment, should the patient also be asked if they have any painful areas? I think this is a must. It's all very well that we inspect the skin, but quite often, particularly in darkly pigmented individuals, as we know, we do not see blanching occur. And so we're going to have to go on other signs, and whether that be first and foremost, can the patient feel discomfort over a bony prominence or other area of tissue? Is the tissue warm to touch? Does the tissue feel boggy or different or indurated in some format? And we need to be looking at other signs and symptoms that could indicate that there is a pressure injury occurring in the tissues. The next question is, what are the best heel suspension devices on the market, and where do we get them? That's a real open question, and I spend my life looking for the perfect heel device, offloading device, I think. The important thing is that I don't believe as yet that we have found the perfect device for offloading heel pressure for every individual with every condition. There are some mattresses today that have inbuilt considerations under the heel, either by tilting down the static device or, if you like, the reactive device. I've already mentioned the Nimbus 4, which has a special sensor under the heels that offloads the pressure, specifically designed for the smaller heel circumference as compared to the torso. I think that's a great breakthrough. But I get asked quite frequently, should we still be using heel suspension, things such as booties, etc., if you're using such devices? And I think the decision to do so is very much subject to how well offloaded you think that support surface in the form of a mattress is doing. If you find that the heels are not offloaded, then to use an adjunct heel support surface is a good thing. But in finding the perfect heel support surface, I would encourage you to consider, does it allow for good management of the microclimate, or does it trap heat and moisture? Does it continually offload the heel, or do you find the heel falls out of the device because of either apertures cut into it or because of some loose fitting arrangement of the device? So we have a long way to go, I think, before we find individual heel support surfaces do a good thing. The next question, and I'm sorry it's in such small font, is what does the evidence say about two-hourly turns? That's a really good question. The two-hourly turns, to my understanding, began common practice in the Nightingale era. For those of you who may have worked in a Nightingale ward, that is a long corridor-shaped ward where we had 30 to 40 beds, it used to take 2 hours to get down one side of the ward and up the other when we were doing pressure injury care. So by the time we had turned the person, cleaned their skin, it would take 2 hours to get down and back again. So it became really a ritual of practice rather than a ritual of need. But the two-hourly position turn began to be the benchmark from which we evaluate the need to do it either more frequently or less frequently. So if you start by turning a person two-hourly and you find that the skin is obviously still developing redness, then we need to either do it more frequently or you put them on a device such as an alternating device that does it more frequently, usually a 1 in 10 cycle. So again, you need to determine based on the individual patient need. If on the other hand, you're turning the patient two-hourly and their skin is not demonstrating areas of redness over the bony prominences, then you might try turning that frequency schedule out to 3-hourly, and then again you evaluate that according to need. The next question is, do pillow support cause pressure on the Achilles tendon? That's a really important thing. It depends on the quality of the pillow that you have at hand, and there are great variances in pillows, I find, across all health sectors, whether they be home care or whether they be tertiary care or residential care. So you need to look at the pillow. You need to make sure that it is a reasonably comfortable pillow, that it isn't going to contain hard lumps and bumps. You need to know that it's well positioned along the limb, not just under or bunched up under the Achilles, because you need to avoid Achilles tendon pressure, otherwise you'll have a similar problem to Achilles. That will be his mortal site. So you want to alleviate the pressure, and to do that it needs to be extended across the leg, along the leg rather, not just under the tendon. Thank you for these questions. They're good. The next question is, what do I like to use, or what do you like to use as a heel protection dressing? And they've asked for specific brands. I think the work, particularly the study that was undertaken by Professor Nick Santamaria in Victoria, was particularly useful to us to identify the fact that the silicone multi-layer foam dressing that he used did provide a significant reduction in pressure injuries, not only under the sacrum in his cohort, but also under the heel. And the theory is that, as I've already mentioned, that the silicone foam dressing helps to manage the microclimate and helps also to have some anti-shear impact on the heel. So I think you have to select the dressing really carefully. The evidence to date, there are emerging studies with other brands, but I would encourage you to look at that literature specifically and to look at the brands, to approach the companies who manufacture these dressings and actually ask them, what evidence do you have that this particular dressing is going to eliminate pressure and shear under the heel of the patients that I'm caring for? So thank you. The next question. Are there any suggestions for residents with dementia and neuropathic feet who also have high falls risk? Mostly devices that are used for these either increase the falls risk. And I'm thinking of the heel, please, as well as those on the malleolus. That's a really, really good question. And I was talking earlier to a colleague today about the fact that there are some devices that either have central to their makeup the ability to reduce shear, so they're made up heel devices that have an anti-slip factor, and in bed that could be ideal. Because you want a person to move in bed, you want to actually reduce the friction and the shear against the skin. So slippery fabrics, or for that matter even medical grade sheepskin, may do that really well. But obviously, particularly if the resident or the patient you're caring for has any cognitive dysfunction or they have a need to be put out of bed, then they need to be assisted because there is a great risk of falls. So it either means that those devices are taken off when a person gets out of bed, and that is fine if it's a scheduled time and it's a supported help with ambulation. But if the person is independently getting up and they're wearing something that's very slippery, then we need to reconsider, because the risk of a fall is a considerable thing. And again, this is another consideration that I don't as yet think that there is the perfect heel device for every patient, resident or client that we have in every situation. The next question, is there a significant difference between static and active support surfaces? And they've mentioned here bed surfaces. Yes, there is. And again, different client conditions will lead to different device selections. But usually the active and rather the reactive devices work on the principle that the patient will immerse into the media, whether that be foam, gel, or air, or combinations. Where the active devices work in an offloading principle, usually either 1 in 2, but it could be 1 in 3 or 1 in 4 with some brands, where if it's a 1 in 2, then 50% of the body is elevated from that position at any one given time. So I'm really sorry we've come to the end of our webinar, and first and foremost I would like to thank very much the Australian College of Nursing and Wounds Australia for allowing this to happen and endeavouring that it did, and most importantly for Argyle Huntley for their unconditional educational support to ensure that it did. I apologise for the errors that we had with slides. It was probably my fault, and I thank you very much for your interest, and I wish you well in doing everything you can to prevent and to manage heel pressure injuries. Thank you.